Hello, I'm Dr. Sharon Dudley Brown, and on behalf of CME Outfitters, I'd like to welcome you all to today's educational activity entitled Life Reclaimed, APP's Guiding Patients with Ulcerative Colitis Through Symptoms of Bowel Urgency. Today's program is supported by an educational grant from Lilly. Today's program is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us on our live X conversation at CME Outfitters. Once again, I'm Sharon Dudley Brown. I'm a nurse practitioner at Johns Hopkins University School of Medicine, Department of Medicine, Division of Gastroenterology and Hepatology in Baltimore, and I'm a professor at the University of Delaware School of Nursing. I'm delighted today to be joined by my distinguished panel and ask that they introduce themselves.
Hi, Sharon. Thanks for having me. I'm Dr. Vincy Abraham, Professor of Clinical Medicine at Houston Methodist and Weill Cornell, and also the Director of the Fellowship Program and the IBD program here as well. It's such a great pleasure to be with you and with Kim as well.
Thank you so much. And I think I'll start by then saying I'm Kimberly Kearns, and thank you all for having me today as well. I'm an adult nurse practitioner. I work in the Division of Gastroenterology for Julie Health and Care out of Hoffman Estates, Illinois. And I look forward to an amazing discussion with these esteemed faculty that we have tonight. So with that being said, I'm going to turn it back over to Sharon to get us started.
Great. Thank you, Kim and Vincy. So we're just going to jump right in by first reviewing our learning objectives for tonight's program. Our first learning objective is to evaluate bowel urgency as one of the most life-disrupting and isolating symptoms experienced by patients with ulcerative colitis. Learning objective 2 is to incorporate assessment of bowel urgency into routine care of patients with ulcerative colitis, including endpoints used in clinical trials and updated guideline-based definitions of clinical remission. And our third objective is to develop comprehensive management strategies in bio-naive and bio-experienced patients with moderate to severe UC associated with improvement in symptoms of bowel urgency. First, we're going to get our audience involved with a quick audience response question. How often do you specifically ask patients with ulcerative colitis about bowel urgency? Is it A, 0 to 50% of the time, B, 26 to 50%, C, 51 to 75%, or D, 76 to 100% of the time? Thank you for answering. We're going to come back to that question after our discussion today. So I'm just going to start by reviewing the data, and then I'm going to bring in my colleagues, Kim and Vincy. So first, thinking about the epidemiology of bowel urgency, we know from the data that more than 80% of patients with ulcerative colitis report bowel urgency. So that's a huge problem. If you look to the right, excuse me, you can see that patients on biologics, so these are the anti-TNFs in the left and the non-anti-TNF biologics, primarily vedolizumab on the right, that despite being on these biologic medications or advanced therapies, they still report bowel urgency. So let me ask my colleagues, is this consistent with what you see in practice?
Gosh, I would like to say I hope not. And it really depends on if they're really getting their disease under control, and that for the most part deals with their ulcerative colitis. If their disease is under control, then typically the urgency goes away. But in some cases it may not, and we'll talk more about it. But these are such high numbers. I just feel terrible for these patients who are on these advanced therapies, not just on mesalamine therapy, but advanced therapies, and still having bowel urgency. To me, in my book, this is way too high. I'm not talking 10, 20. I mean, this is above 50%, 75% even. That's just terrible. So I hope not in my practice. I don't think it's as high as this, mainly because I do ask my patients about urgency. I'm curious to see what Kim has to say too regarding these numbers.
Sure. I couldn't agree more. I'd have to say, looking at like the two data points that we have here, right? 80% of patients with UC report bowel urgency. And I'm hoping that that's more of a, these are our clinical presentation symptoms, right? That I think we as APPs need to definitely be aware of, right? That this is one of these patient reported outcomes. But then we look at that data point that Sharon brought up, and I couldn't agree more. Over half of these patients who are on advanced therapies are still reporting bowel urgency. But I think that this lends to why we need to have this conversation tonight, right? I think that if patients are still reporting bowel urgency and are on these advanced therapies, well, maybe, us as clinicians, we could do a better job at reviewing, patients who are having bowel urgency and making sure that we are tightening up, right, their therapies, which I agree with you. I hope in my practice, these numbers are definitely not that high, especially considering I would have to agree, ask more about bowel urgency.
Yes, I agree with the two of you. It seems very high. The percentage of patients on advanced therapies still have bowel urgency. So it is an interesting statistic, but it's a great way to start off our discussion on bowel urgency. So I'm going to pass this back over to Bincy.
Well, in regards to bowel urgency, I had mentioned briefly about getting the inflammation under control, but there's a lot of different aspects to what causes bowel urgency in our ulcerative colitis patients. So I have this diagram here, kind of looking at the colon. And yes, you see inflammation. Sure, inflammation can contribute to bowel urgency because the patient's having increased output, they're having diarrhea, they're having bleeding. And we all know, especially working on the inpatient side and talking to patients who come in with bleeding, we know that blood does not like to stay in the GI tract. And if it's coming from inflamed colon, as in ulcerative colitis patients, then it's going to come out. So they're going to have more frequency of not just stool, but blood and mucus, etc. And that can also contribute to bowel urgency. On the other hand, with inflammation, the patients can have a dysmotility and most often an increase in their colon motility because of inflammation and potentially because of increased volume of not just blood, but stool and water contents where the bowel is not able to absorb back the water that's normally a healthy colon cells should do. So there's the inflammation related changes there and the motility related changes. However, we also need to keep in mind, there are some patients with, you and I probably seen, with ulcerative colitis, and their disease is under control, but they still have urgency. And that could happen when you scope them and the colon looks completely healthy. At least you see good vascularity. There's no ulcers. They don't even have erythema. But sometimes with long-standing disease, the rectum can become really non-compliant. And visually, sometimes we can see this when you do a colonoscopy and you don't see the hostrations anymore. They have this tubular colon. There's more fibrotic submucosal fibrosis that's been going on with longstanding disease. So their normal function, and then again, it ties back to motility as well, but it can at least also to the rectum where it's no longer compliant. So it's no longer able to hold stool as it used to be able to when there was no inflammation. And during time, the other aspect of it is that when they have active disease, patients tend to work on their pelvic floor really hard and in some ways detrimentally to try to keep things in. And sometimes these patients can end up having pelvic floor dysfunction for having long-standing inflammation, and then they're trying to protect themselves from having bowel incontinence. And over time, they could unlearn the right muscle to keep things in place. And even when their inflammation's under control, that can also lead to bowel urgency and ulcerative colitis as well. And the other component of is completely functional, and it can stem from prior inflammation where they used to have so much inflammation. They had bowel urgency related to all their disease activity. We get them under control. And I actually have a patient who has high anxiety over leaving their house because they used to have so much stress when they had so much inflammation that they couldn't leave the house because they were worried they'd have to go right back in or drive only a few minutes and had to find a gas station real quickly or find a spot to go to the bathroom, where now their disease is under control, but that anxiety still kicks in and leads them to have bowel urgency. And now we have to focus not on the inflammatory component of it, but really the functional component, treat their anxiety, treat the post-traumatic stress really associated with their prior disease to get their urgency under control. So this diagram is actually very important. I spend a lot of time here to kind of explain to everyone that it's not always inflammation. We may need to look into other causes, and you just don't ignore the fact that, or don't forget to ask the patient about urgency, even if you see someone who had a completely normal colonoscopy, because non-inflammatory assessment could be, or reasoning could be the reason for their bowel urgency in these patients. So on that topic, you know, some different reasons for bowel urgency, but how does bowel urgency impact a patient on a day-to-day life? When asked the question of different symptoms regarding ulcerative colitis, we have learned in schooling and GI training and so on and so forth that yes, in ulcerative colitis, we need to ask about diarrhea, how often the patient's going to the bathroom. We need to ask about rectal bleeding, because those are main components of ulcerative colitis. But that big question we ask, like, how often do we actually ask our patients about bowel urgency? So there could be a big disconnect, right? Because yes, the patients say, if you ask them about the most bothersome symptoms, sure, diarrhea is high there, like 63 to 74%. Increase in stool frequency, 39 to 58%. But bowel urgency is also up there, top three. 47 to 62% state that is one of the top three most bothersome symptom in ulcerative colitis. If you look here, rectal bleeding is not in here, if you think about it. So some of the things that we ask about, you know, it's not something that may bother our patients. So very important that it's actually affecting their quality of life. And then if we ask about what in their life they avoid because of bowel urgency, it's really one of the top reasons. They avoid social events, work and school events, sports and physical exercise, which are actually all good for you. We all know in general that being social, I mean, it depends on how introverted you are, but, you know, it's a big factor of quality of life, and even just the quantity of life that we have is that, you know, being with other people, you know, going out to do things and not be stuck at home, going out to do events that are important for work, school, things that are normal activities, and sports and getting exercise is very important. But even patients that hate to leave the house because they can't even go walking in their neighborhood because of bowel urgency is really affecting their quality of life here. And on that, bowel urgency is also one of the leading reasons for treatment dissatisfaction in ulcerative colitis. We just went through the epidemiology and looking at the numbers of patients, even on advanced therapy, that still have urgency. So you can see here, even though they're on other treatments, advanced therapies, they could be totally dissatisfied with their treatment because their inflammation may be under control, or it's better, but they're still having bowel urgency because they can't do the normal things in life that's truly affecting their quality of life here. So having said all this, you don't need to take mine or Kim's or Sharon's words for this. Let's actually look at a real patient. I want to thank Sharon for providing your patient for us, and we'll see what she has to say.
For example, I'll wake up in the morning. I don't usually have to go like right away, but I'll be making breakfast or something like that, and I'll get the urge, which for me is like a lot of pressure in my bowels and in my rectum, and I just have to get to the bathroom pretty quickly. And I'll have a bowel movement, and sometimes I'll have abdominal pain with that. Sometimes I won't. And then I'll feel like I'm done, and I'll, get up and try to go about my business, and I'll get the same hit again. And it's like, it can be a couple of times, but it can also be up to like 15, like just back to back. And I'll be in the bathroom for hours in the morning. And so obviously that disrupts my day completely. Thankfully I am a stay-at-home mom, so I don't usually have to get up and go anywhere, but still, like I guess that is one way that I kind of change my schedule to accommodate that. I won't plan things in the morning if I know I'm not feeling good, because it just is impossible to leave the house on days like that.
Great. So as you can see from our patient video clip, she's really normalized bowel urgency. And I think this is what we see and what happens to our patients. And that's why it's really, up to us to really start the conversation. So to my colleagues, how do you encourage your patients to talk about bowel urgency?
Well, I think, some of the very beginning elements of it is helping actually a patient define what bowel urgency is, right? I think when we start off, when we just ask, do you have urgency? I think sometimes it really helps as a provider to begin by explaining or defining what that actually is. Dr. Abraham, I know you've got some great examples of that as well. And I know you and I and Sharon have all talked about this in the past, but I think just to almost normalize that conversation from the beginning is kind of where I really start and help with the definition.
Agreed. And a lot of times patients are uncomfortable bringing up a topic, even though they're in GI clinic, we're talking about their poop and diarrhea and belly pain and all of this stuff. Still, telling a provider that, oh, I can't make it to the bathroom on time, it's a very embarrassing topic. We may not think so, but I think that's where we need to keep that in mind so we can bring it up to the patient and normalize, like you said, this conversation. Because if we don't bring it up, the patients don't bring it up. And there's lots of studies looking at, from a patient's perspective, they don't bring up the urgency component, even if they know what that means to us, because they're embarrassed to talk about it and or don't think it's actually important because we're only asking questions regarding diarrhea and rectal bleeding. So I think this is a very important topic that as we're educated to bring it up to the patient, because we shouldn't expect our patients to bring it up all the time regarding bowel urgency. So again, how do I kind of bring this up in my clinic? Really establishing that good physician or provider to patient relationship, get them comfortable talking about embarrassing stuff and so we have it where I try to become, yes, I'm their provider, and but become like their friend in this long game, because these are chronic diseases, right? It's not that we're just seeing them for one time and getting them a prescription, they finish something and they're done. They're coming back to us. So building up that relationship where they feel comfortable discussing it, normalizing it, and bringing up specific questions about urgency. And I love what you have up on the slide here, Sharon, about asking these questions where some patients don't know what does urgency really mean? The whole question about putting it in their time of, how do you need to rush? Do you have this immediate need to go to have bowel movement? Or a lot of times something simple, taking away the GI thing and really ask them, are you really changing your life because of this disease? And that might bring up some of these topics that the patients may not have initially brought up to you as well.
Right, and I just want to draw the attention to the audience to the right-hand side of this slide. There are clinical resources available for you all to download from this presentation, and it includes some of these questions as well as lots of our other resources that we're going to talk about later on. So let me move on. What was brought up was obviously asking the right questions, and patients don't typically use the word urgency, right? They don't come in and tell us, I'm having urgency, or usually they don't. So it's really up to us to get that information. So it's not just, this was brought up before, I believe by Bincy, it's not just the number of bowel movements and bleeding, but we need to ask them about the urgency. So in my clinical practice, in my EPIC note, I use the Simple Clinical Colitis Activity Index for ulcerative colitis. You can look at the section on urgency. It's on the top of the right-hand side of this slide, and you can see that it uses words like hurry, immediate, is the toilet nearby, and it also has the word incontinence, because we, again, don't see patients typically come to us and say, I'm having episodes of incontinence. No, it comes up in a conversation when we're asking them about how they're dealing with their ulcerative colitis. So I find that if I bring this up, do you have to rush to the bathroom or hurry? Have you missed making it to the toilet? Oh, so you've had some episodes of incontinence, and then talk about that. So the SCCAI is one way to help to talk to your patients, and also a tool to help document their symptoms in their notes. I'm going to pass this over to Kim.
Thanks, Sharon. That's such a great example. And I think that it's so helpful to help quantify a little bit about what we're doing. So especially when we're talking about urgency, right? So for patients that may report bowel urgency, and as both Bincy and of course Sharon has talked about, most patients don't walk in and say, I have urgency, right? So this really lends to opening this discussion. We've talked about that, but now how in clinical practice do we start utilizing tools to actually evaluate urgency? So what you see up here, of course, is a tool, okay, that is a validated rating scale that we may be able to use to incorporate in our clinical practice. So what we're seeing, of course, here is the urgency numeric rating scale for patients with ulcerative colitis. As you can see here on the slide that we have presented, it's a scale that ranges anywhere from 0 to 10. And as you can see on the scale, 0, of course, is no urgency. And then, of course, 10 represents worst possible urgency. Now, I'll let you know, this scale has been evaluated and, of course, validated. Patients looked at the scale and thought, yes, this is a very accurate way as to help me describe where my urgency lies within this range, right? So patients were then asked, how severe was your urgency? And that, of course, was defined as sudden or immediate need to have a bowel movement in the past 24 hours. And then, of course, they would use this rating scale, again, 0 to 10, to help actually quantify where they were on their urgency rating scale. So how do we actually take some of this information, right, and then pull it into practice? So what I want to point out, first and foremost, is this bottom bullet point, right, is that patients with mild to moderate bowel urgency were actually 5.9 times more likely to have active disease, right? So this lends to the fact of us really needing to talk about bowel urgency. And even as Bincy pointed out, we have to ensure that it's an inflammatory process as well, right? But we recognize that patients who have mild to moderate bowel urgency are more likely to have active disease. But now when we look at this scale, what does this mean to us then? If we're going to use this as a scale with our patients or possibly even move it into clinical practice, well, we know here, and as you can see from the definitions here, a clinically meaningful improvement would be a 3 or more point decrease from that baseline in that urgency scale, right? And remission would then be the number of 1 or less. So again, kind of a tool that maybe we can utilize to help assess our urgency. And again, I know our patients love numbers and tools, so pulling this out and possibly even having our patients, you know, look at the tool as we're moving through, as Dr. Abraham pointed out, their journey, right, of IBD, and looking at their urgency journey as well. With that being said, I'm going to turn it over to Dr. Abraham to move forward with how we would actually use some of this in our clinical practice.
Thanks, Kim, for showing that scale. So I just wanted to give you guys an example of what I have in my patient, like in my Epic EMR system. For every UC patient, I have the Mayo score and the simple UC activity index score there. And this is one example of, the Mayo score we're aware of because of clinical trials. That's like the #1 scoring that's used, where we have the stool pattern, the rectal bleeding, and then of course the physician global assessment, endoscopic findings. So sure, that's great to put in there. And also useful for like future clinical research and things like that. But the activity index, see, you saw the earlier index in separate sections, but I have it set up in Epic where I can just highlight the numbers, like, okay, they're having about 6 bowel movements per day, or they're waking up in the middle of the night, or if it's 0, they're not waking in the middle of the night, they get a score of 0. You see there's an urgency score in there. So I just give them those scores and I add all of these in and give them a number. And if you look at the UCI like score, the patient had like mild to moderate disease earlier, but they've been in remission for the last, it went from 4 to 1 to 0, 0, 0, 0. And this was a patient who had everything was nothing was highlighted. They were doing very well, no bleeding, no urgency, just having 1 to 3 bowel movements per day, and that's it, and no external manifestations. This person's been in truly clinical remission as well. And then endoscopically had been in remission, but a most recent score, I didn't have a recent endoscopy, but I'm doing intestinal ultrasound in clinic, so I can include that in there, even though it's not part of the official score. I incorporate the objective assessment, but as well as the clinical symptom assessment. But this is where I simply have in my epic thing. So when I'm writing the history of present illness of patients describing their symptoms, I just click on these areas and I just put in a score there. And depending on how fancy your EMR system is, you can have it incorporate where you can just press buttons, or simply just add these numbers up and put it in yourself as well. So it doesn't have to be very complicated, but this automatically makes sure that I am asking these questions into my clinic, or if I have trainees coming in, if I have a student or a resident or a fellow or another APP following us, they see this, and this is something that's automatically incorporated. I don't even have to think about asking them because it's already as a checklist for my patients. So it takes out the guessing game or having to remember anything, in these patients as well to ask about urgency.
All right. We've talked about a lot about patient's journey and incorporating this into practice. Yes.
Can I interrupt you for 1 second? I'm very sorry.
Yeah.
I just wanted to tell the audience that I am looking at the questions that have been put into our system, and I am reviewing them. Most of it we will be covering. I'm going to look back at this at the end of our presentation to make sure that we have covered it. So keep putting your questions in, but I am the one who's monitoring it. And Kim, go ahead. I'm sorry.
Oh, no, of course. Well, we appreciate all the questions. The three of us love to chat together. So I think if all of you who know us, bring us questions, send them in, right? So we talked a lot about this patient journey, incorporating things into clinical practice, and what a better way to, kind of pull everything together, but throw in a patient case, right? Of course, that's how this usually goes, right? So we've got a patient here. This is a 40-year-old male. This is Chris. He's here for his follow-up visit. This is his 3-month regular follow-up checkup, right? So he was diagnosed with UC about 2 years ago and started on infliximab shortly after diagnosis. So I hope everybody's bells and whistles are going off, thinking, okay, he had to have moderate to severe disease if he was started on infliximab about 2 years, right after his diagnosis. So with a symptom review though, right? So here comes Chris, we're asking him all the questions. Now, if we're like Dr. Abraham and Sharon, we've got our little, our notes, our dot phrases are already coming up, asking us all of our questions ready to go, right? So he's having 2 to 3 bowel movements per day. And you kind of ask that and you put 2 to 3 in, right? He says there's no blood in his stool. He's got no abdominal pain, but then, kind of relates back and says, sometimes my bowel movements may be triggered by fatty or spicy food. So, 2, maybe 3 bowel movements per day is kind of more of his answer, right? His current treatment is infliximab at 5 milligrams per kilogram every 8 weeks. And Chris is a wonderful patient, and he knows that he needs to have his labs and everything done ahead of time before he comes in for his visit, right? So his CRP is less than 0.8, his fecal calprotectin is about 56, and it looks like that was about 3 months ago. And he had a normal colonoscopy as well about 3 months ago. Normal meaning no evidence of disease. So let's just clarify that. All right. So with that being said, I think as we're talking about our patient cases and we talk about the importance of urgency, as we move through our next discussion, which we're going to move into more of a faculty discussion, and the reason we really want to put this in here, and we spent a lot of time chatting about the 3 of this, is because bowel urgency is often ignored. And as we've talked about, not a topic that we bring up as providers, right? So, and we talked about the epidemiology, what a devastating, symptom this can be for some of our patients. So in this, and again, we would like to, of course, create more of a role modeling as to how would we actually do this conversation in clinical practice, and what does that actually look like? Because a lot of times patients downplay their symptoms, right? We know that. They actually may not call out urgency. So with that, we know that it's sometimes difficult to draw these things out of our patients and really get down to the bottom of it, literally, because that's what we do in gastroenterology. So with that, Dr. Abraham and I are going to move forward with a little bit of a patient case here. So with that, I'm going to be the provider, and Vinci is going to be our patient for today. So here we go. I'm going to walk right in. So hello, how are you doing? I see you're here for your 3-month follow-up today.
Hi, Kim. It's going okay, I guess. I'm doing okay. Yeah. Thanks for seeing me today.
It's a pleasure seeing you as always. But I hear you say it's going okay, but how are your symptoms of your IBD? How's that going?
Well, it's about the same as last time. I mean, you told me at the colonoscopy, everything was looking good. So I guess I'm good.
Well, thanks so much for getting all of your labs in ahead of time, and they look good. But how are you feeling? Tell me a little bit more about how you're feeling today.
I'm feeling okay. I, of course, had a visit with you. So yeah, and I'm glad I saw the labs on my chart, and they look good too. I'm just, feeling tired, but not sure if it's work or stuff, but I'm okay. Yeah.
Hmm, tired. Is the tiredness new? Can you tell me a little bit more about that?
Well, I mean, I have a lot of work, but it's not, I don't know, it's not really new. I just, there's work stuff and you tell me everything is okay. So I don't think it's something to do with my GI tract, but I just haven't figured out what to do, like a good routine for me, because I do have to get up early and then I need to leave my house on time, but I have to leave, I just kind of get up early to make sure I get my breakfast, and otherwise I get so hungry when I get to work. But I have to have my breakfast pretty early, and if I don't get up early enough and then eat my breakfast to give me enough time before I leave for work, I won't eat because I can't. I can't get to work, and I can't deal with all that stress of it, because sometimes I'm just tired by the end of the day and I just kind of oversleep and press the snooze button too many times. And so then I don't eat until I get back home.
All right. So I think this is a good moment to hit a pause button, right? And I think we can clearly hear that from our patient, and just by opening up the door and just having an additional question when you're asking, how are you actually feeling, right? And having a moment to have the patient describe what's going on. Now, he clearly, in this situation, or Dr. Abraham, has not clearly said that there's any urgency involved, right? We have not heard the word urgency at all yet. But what we're hearing is that there's definitely some changes, right? The patient's tired, they're, avoiding some food, they're not eating meals. And I think this is a great opportunity to really dive in and to get some additional information about what is actually happening with this patient. So again, from here, I would probe and say, so why are we not having meals or stressed over meal times specifically, prior to going to work, right?
Okay, so well, if I eat, I don't know, I just have to run to the bathroom sometimes. Sometimes I don't have to run, but sometimes I do. I just don't want to leave the house and then worry that I'm not going to make it before I get to work, because I do have about a 30 to 40-minute commute. And I'm kind of tired of trying to go into a store and hoping it's open, or find the next gas station, because sometimes I worry that I can't make it. There was one time a long time ago, I just had an accident and I just didn't want to deal with that because I was so embarrassed. I got to work. I mean, it hasn't happened, but I'm just so worried about it that I just don't want to have to deal with having all of this issues with having to run to the bathroom all the time. Yeah. At least when I'm at home, if I eat breakfast and I have to run, I'm home and I'm not driving.
I'd like to thank you so much for sharing that information with me. I think it provides us a lot of information about what next steps we need to take in order to help with managing some of the tiredness, which is related, I think, back to some of the, not wanting to eat, because it sounds as if you're having some issues with your bowel movements, triggered by eating. Would you describe having a little bit of urgency with having a bowel movement?
Yeah, I guess that's what you call it. Yeah, I'm always thinking of being rushed to the bathroom, but yeah, urgency sounds like a good word.
Great. Well, let's, and then from here, I think we'll pause from the patient modeling. I think from this point, Dr. Abraham, is there something else you'd like to add into any of that from a conversation perspective? I mean, now that we've gotten to
not as
what
Chris,
was
as the
about urgency.
provider. You mean not as Chris, as the provider. No, I think this is, hope I did a good job pretending to be Chris here, but this is actually a very normal scenario where the patient's, it's like hesitant to say something, but maybe they don't know how to explain it. They're just,
Right.
they are tired. They're like, oh, well, and the other part of it is they're also confused, right? Like you said, everything was good. My colonoscopy was good, so I shouldn't be having a problem. And so is it just me? Is it in my head? Like there's so many of those questions that maybe the patient is thinking about. And that's why I didn't jump to even knowing, the information, knowing as a provider what to ask. Like this is a typical patient scenario. So unless you ask about it, they're not going to tell you unless you pry it out of them. So I think you did a great job of pulling out, okay, it's some hesitancy in, me answering the question. Is it's tiredness? You had something to grasp and you asked more open-ended questions where the patient can feel comfortable discussing it. Now, I guess one could argue, gosh, we're busy in clinic. We don't have time to say, hey, how are things going in life and all of that. So, and this was kind of meant to be like an eye opener of you may have to pry, but then if you ask the question about urgency, you may be able to get it earlier on, but in a lot of cases, if you don't pry, you're not going to get it. So without having to beat around the bush or wait for the patient to tell you, you can directly ask the patient. So it was more of like really a practice of maybe what not to do, because it might take forever to get that answer from your patient unless you say, okay, you're tired, but what else is going on? Are you having, you said no pain or diarrhea, but are you having any urgency? Are you having any other symptoms that may be linked that we're not talking about, or something like that, where you can try to get that information faster? Yeah.
100%. And I think part of it too is also, just saying that you have the time, right, to dive in a bit deeper, and not like the patient says, I feel okay, it's good, I'm a little tired, and then say, well, your labs look okay, and then not pry into anything else, right, Dr. Abraham? And I think that part of this is really being able to say, and I hope that everyone recognizes the modeling of asking about, do you feel like you have urgency? And then even, and again, I would probably define that a bit further too, talking to the patient, just so that they were then able to actually articulate that a bit better. Because, as Vinci pointed out too, the patient was a little bit confused, didn't know really how to explain that to the provider asking the question. So I think with that, we'll move on to, yeah, go ahead. Sorry, go ahead, Sharon.
Yeah, so let me interrupt. There is a couple of things in the questions. One is a comment. Really, older people seem to be more free to explain their symptoms. And it's a little bit harder for younger people. And I would add that it's also the young male, like in this situation, that young males tend to soft pedal their symptoms. And two people brought up how it's difficult to do all of this in, a 10-minute appointment, right? And so perhaps in response to that, somebody else said having patients keep a log and then bringing it in to show us prior. So I think those are very good points that people have put in there. And I think we're going to move forward to the approach.
Yeah, thanks so much. And I agree. And I think too, having, as both you and Vinci have pointed out, having, kind of talking about this from the beginning with patients also helps with normalization and then getting to that endpoint a bit quicker. So how do we actually approach bowel urgency? I think Vinci gave us a really great overview that we have to realize that, we have to have an assessment for bowel urgency, but also recognize that it comes from many places, right? So let's take a look at this algorithm a little bit quickly here to our approach to bowel urgency. So first of all, a targeted assessment for bowel urgency. We, of course, as providers, have to, of course, get to that point. Is the patient having bowel urgency, right? And then we talked about the newer kind of validated rating system that's available, the UNRS, that we could potentially utilize in clinical practice. So first and foremost, is this inflammatory related, right? You can see that's our first part of this algorithm here. If it is not inflammatory related, well, then we talk about initiation or effective therapy or optimization of current therapy, which we're going to get to in a bit. But let's talk a little bit about, if the inflammation is controlled. We met Chris a little bit ago, right? His CRP was okay. His fecal calc was was relatively normal. He had a colonoscopy, right? But he's still describing a little bit of bowel urgency. And again, bowel urgency doesn't always have to come from underlying inflammation or active inflammation. Could be a sequela, right, of long-term inflammation. But I think part of having this discussion today is really kind of understanding how to approach bowel urgency if it's maybe not related to inflammation, right? And I think that this is a fair and balanced way to, of course, approach that. So from a pharmacological and non-pharmacological intervention, we can start with diet modifications. There's a suggestion here of a low FODMAP diet, or again, just removing lactose is something that I sometimes recommend. What about medications, right? Utilizing antidiarrheal medications for patients with bowel urgency, bile acid sequestrants, tricyclic antidepressants, or if necessary, pancreatic enzymes. Addressing, and of course, as Dr. Abraham had pointed out, the anal rectal dysfunction, right? So really assessing, is this something that has to do with more of a function, not necessarily IBS functional component, but an actual dysfunction, anal rectal dysfunction. So thinking about biofeedback or even pelvic floor therapy. And I would like to say that this last part, this psychosocial support, I think that this actually falls into both inflammatory and non-inflammatory. I think that that can actually live in both lands, to be honest with you, because I think that there's still a lot of elements that lives because of even the symptom of urgency in itself. So again, psychotherapy, and of course, specifically discussing coping strategies or other mechanisms that help with managing the stress that correlates with bowel urgency. With that, I know all of us have very different approaches of how we approach bowel urgency in practice. I'm going to open it up to my esteemed faculty and see if they have anything else to add to that.
No, I think you did a fabulous job. I always start with, is inflammation controlled or not? And if it isn't, I always start there, because you could have all these other factors. And yes, you need to address them if they are popping up as an obvious thing. But until the inflammation's controlled, yeah, the others could help, but it still won't treat the underlying problem. So yes, number one, get the inflammation under control. If you see evidence it is, and then look into what could be the other factors. The other factors without, I know, talking about all these things, and the big question that came up was actually, how do we assess all this in a 10-minute, meeting? Well, this is where you have to kind of start looking clinically at with the patient saying what you already know. So you may have a lot of this information before you even walk in the patient's room of what has happened in the past, what medications you've tried in the past, if they have prior history of anxiety, and or if they've had issues. And one of the things about anal rectal dysfunction is if you don't think about it, you won't actually assess for it. So keep that in mind as a potential etiology of urgency or other, incontinence, etc. So if you don't think about it, then you can't send them for anal rectal manometry assessment, or be able to treat them. And I can tell you, like almost 90 to 100%, like 99% of my patients, I should say, has actually benefit from biofeedback therapy when they've had some sort of anal rectal dysfunction. So I can imagine that's like almost everybody. If I don't thinking about it, imagine all the patients who may have had this and I hadn't sent them for assessment as well.
Absolutely, absolutely.
So we've talked about in that prior slide had divided, sort of, I think we all approach inflammation first, because we're thinking about, right, the IBD. And then we go to, well, if the inflammation is controlled and we have all those data points, then we move to, as Kim was suggesting, you have to sort of think big here with these different options. I know somebody wrote into the question about fecal incontinence, and that is another workup, and Kim touched on that. I think with our case, we do know that Chris's inflammation was controlled, right? And somebody said, well, what do you do when you have data points that are conflicting? I do think the colonoscopy is the gold standard. So if there's a question between what they're saying and calprotectin and labs, then I think we have to reflex to a colonoscopy to actually look and figure this out. So I think that was a very good question that somebody wrote in there. I'm going to move towards options for treatment for inflammation. Now, so what if this was not Chris, it was a different patient? Or what if Chris's inflammation was not controlled, for example, either on the calprotectin or the labs or his colonoscopy, and how would that change our management? And it's interesting, somebody also wrote in asking about topical treatment. And I do think that if somebody is on an advanced therapy and they have a little bit of rectal inflammation on a scope and they're having some urgency, yes, topical treatment. And you can even alternate with steroids and mesalamine. So that was also a very good point. So I wanted to bring that up. But I believe now that Vincey's going to talk to us about advanced options for uncontrolled inflammation.
Correct. Yeah. So that's a great point you brought up, Sharon. Like, even if they're already on these advanced therapies, I've successfully, and there's been studies looking at this too, that adding the topical therapies can definitely help these patients. So don't shy away from using it just because they're already on advanced therapy. And sometimes it may be a short-term thing if they need to get some of this proctitis under control and without having to completely change a mechanism of action. If they're, they've gone from pancolitis and they went into remission, they just now have a little bit of, proctitis causing their symptoms. So as you can see listed here, we'll go into every single medication, but you see, this patient was on infliximab, standard dosing. I'm a big proponent of doing therapeutic drug monitoring. So I always like to optimize their dose or frequency of medications that we can check levels on and optimize as well. And I like to do that before I would move on to a different mechanism agent, because I feel like I've done the best with that agent before I moved on. But we have the anti-TNFs. We have anti-interleukin 12/23 and currently one anti-interleukin 23 option, mirikizumab. We have two S1P receptor modulators, ozanimod, etrasimod, two JAK inhibitors, keeping in mind that JAK inhibitors can only be used after anti-TNF use, intolerance, or failure based on the FDA guidelines, and of course anti-integrin vedolizumab. So really choosing what to do here. For example, with Chris, if he had active disease, first thing I would do is check his levels of infliximab. If he had low levels, I try to increase his dose or frequency. If he had positive drug and anti-drug antibodies, I would consider moving him on. And like most often, I just move on to another mechanism, but you could switch him over to adalimumab or golimumab, but monitor his drug levels closely so he won't develop anti-drug antibodies or add on an immunomodulator with another anti-TNF. On the other hand, if a patient says, you know what, I know I've been on infliximab, I know it's not working, I don't want to keep doing it, then look into other factors, patient's preference of IV versus sub-Q, oral therapies, and safety considerations, comorbidities, any contraindications. I won't go into all those things, but take those different aspects into account when you're choosing an initial therapy, or if someone's failing it, find out where they're failing it before moving on to another option here. Now, speaking of bowel urgency, if you look, you saw all these options. Now, there were 3 medications within that group that actually assessed bowel urgency in the clinical trial: mirikizumab in LUCENT 1 and 2, etrasimod in the Elevate UC trial, and upadacitinib in the You Achieve and You Accomplish trial. All of these agents showed improvement in bowel urgency when you're comparing the drug to the placebo in both the induction phase and the maintenance phase. Now, other agents that you saw listed have not specifically been studied for bowel urgency, but in my book, and I'll get everyone else's input as well, I really don't necessarily only use these 3 medications in my UC patients just because a patient has bowel urgency plus UC. I keep this into account that, yes, we've studied it, and we can also tell our patient the clinical data that these medicines did improve bowel urgency. But again, if you get a patient on any medicine that helps reduce the inflammation, that's going to be the #1 key to getting their urgency also under control, especially if it's linked to inflammation. So I don't necessarily only limit my medications to these 3 if a patient has active UC and urgency, but just letting you know these are the 3 medications that we're actively assessing bowel urgency in the clinical trials. Kim and Sharon, any other thoughts on this, or do you have different ways of different medications, or you only use these 3 in bowel urgency patients?
I couldn't agree with you more in regards to your comments on bowel urgency and the utilization and these, these therapies specifically. Like for UC patients, you're right. The list that you had on the previous slide. But and selectively, these are not just 3 that I would use to manage my UC patients. But I think I just want to point out is that, urgency, as we've mentioned all along, is not consistently assessed in UC clinical trials. But what we're starting to see a little bit more frequently, as we just noted here on these 3 drugs and these 3 trials, right, that we now are actually starting to assess bowel urgency in clinical trials and utilizing, some of the tools that we had mentioned earlier in this discussion, actually in clinical trials. So I think that we're maybe moving the needle a little bit. What do you guys think?
Absolutely.
Yes, hopefully that's exactly the point with these new clinical trials that
Yes.
people are assessing bowel urgency. I think it's important to tell patients that, all ulcerative colitis involves the rectum. So that's the driver of urgency. And so, yes, we are all going to use all of these therapies to treat based on a lot of the other factors, which were previously discussed and, have been, published previously. So I do think there's a lot to go into choosing a medication, but just wanted to point out that everybody who has UC has rectal involvement. Okay. So let's revisit the audience response questions from earlier. So now, how often will you specifically ask patients with ulcerative colitis about their bowel urgency? Please choose one answer now: 0 to 25%, 20 to 50%, 51 to 75, or 76 to 100. Okay, so you can see now that in the pretest, the majority of people chose 50% chose 0 to 25% of the time. And in the post-test, that was lowered, so that's good. Having a little trouble moving this down here, sorry. And I'm having trouble with
Like
this.
70%.
Karen, I can help you out with
yeah,
that. Yeah, it looks like in the post, in the post study, 76 to 100% of the the participants said that they would actually ask about bowel urgency. So you did an amazing job here, from pre to post, with a dramatic change here.
That's great. Okay. So before we finish with some more question and answers, I'd like to offer some SMART goals, which are specific, measurable, attainable, relevant, and timely. These goals are specific action items you can immediately start using in your practice. So the first is proactively screen patients with UC for bowel urgency symptoms. And the second is to address bowel urgency in patients with UC through an individualized treatment plan, such as the one that we presented. Remember to ask, if you want to ask a question, select the Ask Question tab. Please include the faculty member's name if the question is specifically for them. And while you are writing that, we will also bring up that about the gastroenterology hub, to visit our gastroenterology hub. And you can find the slides from this activity in the course guide under resources tab of this program. The gastroenterology hub is at the cmeoutfitters.com. Remember also that to receive credit, participants must complete the post-test and evaluation online. I checked again. I do not see any new questions. It's interesting, somebody put in about doing a study, asking people if they work with UC, do they work from home more often because of urgency, right? And limiting their daily movements, right? Like the patient case that we saw, she says, I'm a stay-at-home mom, right? So she says, I always have access to the bathroom. So that's a very interesting point that somebody brought up there. Somebody else was talking about fatigue. I think that's a whole other talk, but I can certainly appreciate that. So unless there's any more questions.
In regards to the working from home, I've had several patients have asked me, hey, can you write a letter to my employer stating, because I have ulcerative colitis or IBD in general, to do that. So yes, it is a common theme. I mean, not everyone, because again, we're social creatures, especially during COVID. I think a lot of us got tired of being only at home and, without going back into work. But yes, in general, there's been a lot of, there's several patients who have asked about that as well. And then that fatigue component of it, I think it's like all can fit in, right? So if a patient has urge, like Chris, for example, he has to get up early enough in order to eat breakfast. So he may be limiting his time going to sleep or not. If he doesn't sleep enough, just sleep early, then he may wake up late and because he doesn't want to miss out on his sleep. But if he wakes up early enough to have his breakfast, he may be tired from not having enough sleep too, because of the urgency component. And of course, and fatigue, yes, like Sharon, you said, is another thing to discuss. There's so many missing pieces of the evidence. Yes, active inflammation can cause fatigue, but even patients with UC and Crohn's who really have had their disease under control are still fatigued, and we still haven't sorted out the exact reasons. I do tell them about getting enough sleep, making sure they're getting enough exercise, along with the stuff and getting appropriate nutrition and all of that, along with the, treating their IBD, the colitis and their GI component of things. The other thing to ask about is anxiety or depression too, that could also contribute to fatigue. But I also annually to make sure they get all their nutritional assessment, making sure that iron levels are good, vitamin D, all that good stuff too. It's kind of an adjunct to making sure you're treating the patient as a whole, not just only their GI tract itself. Yeah.
Couldn't agree more, Dr. Abraham. I think, as I was listening to you talk, I was like making this picture here, like it's the whole patient, right? We have to think about everything that kind of coincides with them and their journey that they have with their IBD. But again, I think that lending to, there was a question in the chat about the urgency score. Unfortunately, it does not assess fatigue. It's just validated to evaluate urgency. But the question was in there, do you have any a scoring system for fatigue? Does anybody use a scoring system for fatigue? I have to be honest with you, I don't. I look more back at the psychosocial component of things, specifically asking, when I hear patients talk about stress, about work-life integration, so on and so forth. I don't have a tool for that specifically, but I do spend some time chatting about that. Do either of you have a tool that you utilize for fatigue specifically?
No.
There are validated scales for fatigue scoring in clinical trials, and that's what they use in the clinical trials, but I don't necessarily use them in my clinical practice. Yeah. Again, having another score to add to, but fatigue is something that patients are happy to tell you compared to urgency. They're like, oh, I'm tired. They're the number one thing. They'll tell you more about that, so I don't necessarily have to pry that from them. They're like, I'm so tired, can you help me? And that's more of a challenge for us than getting that information in.
Yeah, there's a question about there's more questions coming in. I'm sorry, guys. Phone apps and a question about diet for urgency. I would say patients usually control their diet themselves, like no spicy foods, that sort of thing. I don't think that there's anything specific. I believe Kim mentioned about, removing dairy to see if that's part of it. So I think it's part of that assessment to see if there's something. And then that question about phone apps for tracking urgency. I'm not aware of any apps that track urgency.
Yeah, so for the diet, I always ask them, like, are there specific foods that tend to cause you more
Yeah.
urgency? And then I'll tell them to hold off on that until we, figure out what's going on, essentially assess what's going on. Is it inflammation or something else? I don't know of any apps, but I haven't also looked into it either. But that maybe is something that if we do find it, could be a potential resource that we can add to the website possibly, and we can ask CME outfitters for that. That'd be a good question. But patients can also, they don't necessarily have to put in the app, but they can also kind of note it down. Or so if they're having significant urgency, just I tell them, okay, write those things down. Maybe have a 24-hour period of where they're having more stress, or did they eat something specific? And then they can bring that into our clinic visit at that time to discuss that. Those triggers, essentially. Yeah.
Okay, I think we're out of time. I want to thank the audience, and I want to thank my colleagues again, Dr. Abraham and Ms. Kim Kearns, for joining us today. And thank you so much for all of the work that you all do.
Thank you, Sharon. Thank you.
Thank you, everyone. Thanks, Sharon. Thank you, Vinci. Great time with everyone tonight.